Oh, can thyroid disease get worse during puberty? So you might have looked from that paper that some people feel that it's almost like two separate populations, that yes, the people in their teens essentially might have worse eye disease, but generally puberty is not going to reactivate disease. So if you had eye symptoms when you were young, in other words, under the age of 13, they likely won't recur as long as you have good thyroid function and you're not smoking. So the answer is it's typically a worse disease the older you get. So the closer you get to 18, just like that first child I showed who was 16 when I met her, the more like your disease is like an adult. But there are very, very few kids I've seen at CHOP with such severe disease. For the most part, it's just the eyes are very high and the eyes are out, but the eyes aren't crossing. Oh, wow. Should thyroid eye disease patients avoid getting contacts? Are contacts beneficial because of lubricants? And a teenager wants contacts. I think you're fine wearing contacts. It doesn't hurt to try them, but it can be a challenge. Sometimes it actually helps because your eye doesn't feel as dry. The critical thing, and I'm not a contact lens specialist, has to do with the fitting of the contact. So sometimes a contact lens specialist will give you a slightly looser contact because your eye closure isn't as good. And so the other theory is some people will give you a slightly tighter contact because you don't have the closure and it might ride down. The problem is then it's more irritating the eye. So it's total trial and error. Are there any treatments we can do now to lessen symptoms of thyroid eye disease or prevent them from getting worse? So that's really where Dr. Bauer and Agzik come in, because the eye disease symptoms in terms of progression are directly tied to your thyroid function. And so the only thing you can really do, to my knowledge, is not smoke, not be around smoking, and to have better control of your thyroid function. And some people feel that stress may be a factor, but I don't know what we can do to avoid stress. It's like a part of our American lifestyle.
Right. It comes down to the TSI levels again. So whatever we can do to get those as normal, and as quickly as possible, because there certainly is a flare. As those numbers go up, then the eye disease can worsen. So compliance with medicine or seeking definitive therapy, usually surgical options rather than radioactive iodine, are of greater benefit. It also just listening to Bill's talk reminds me that, not a contact specialist, but we have patients that travel and see us at CHOP, and they have eye physicians that are local, or they have other subspecialties that help them locally. But it really does take sub-specialization, and Graves' eye disease, I think, falls into that category as well. It isn't as common as in adults. It really does take someone who sees it frequently to know if and when surgical or corrective options are necessary. So the surgeon is amazingly important, and I think the eye physician as well, and that's why we have a nice team. Very fortunate. So, does everyone with hyperthyroidism have Graves' disease? All right, that's a good question. They're all good questions, actually, right? I could have listed the differential of hyperthyroidism, but the most common cause of hyperthyroidism is Graves' disease. But when patients come in and they have the symptoms of hyperthyroidism and they don't have antibody levels that are elevated, or they don't have a T3 that I expect to be higher than the T4 when they initially present, or they have something wrong as far as their exam, one side's bigger than the other, I feel a nodule, then you start thinking about other causes. The second most common cause is a nodule, a thyroid nodule that's autonomously producing thyroid hormone. So in that situation, it's not Graves' disease, it still is hyperthyroidism, and in pediatrics, the cure for that is to remove the nodule, which is to remove the half of the thyroid gland, a lobectomy. In adults, sometimes people use radioactive iodine to treat, but in pediatrics, for nodules that are producing too much thyroid hormone, surgery is the option, is the treatment of choice. There's a bunch of other less common causes. You can have genetic mutations in that receptor. That's uncommon, but it does happen. You can be on certain medications. And then there's a very rare person that actually takes thyroid hormone and doesn't tell us. So factitious hyperthyroidism, and we can figure it out because we can check a thyroglobulin level, a certain protein level to figure it out. So there's a little bit longer list, but not every person with hyperthyroidism has Graves'. It just happens to be the most common explanation for it. What is SSKI? So SSKI is supersaturated or saturated solution of potassium. So potassium's symbol is K iodine. So SSKI is supersaturated potassium iodine or saturated solution of potassium iodine. We require about 100 micrograms or so of iodine a day. A drop of SSKI has about 50 milligrams. So it's a huge amount of iodine compared to what we would need otherwise to make a normal amount of thyroid hormone. And the way that much of the endocrine system works is if you give somebody, because a lot of things are released in pulses and at a certain amount, and if you give too much of it and constantly, you turn off that endocrine organ. So we can use SSKI to turn off the thyroid gland because even though it doesn't seem like it would make sense, we're giving kind of the fuel to the fire type of thing, right? The gland's already revved up and we're giving it more iodine to make more thyroid hormone. There's actually a protective reflex for our bodies have that's just part of our body to turn it off. And when we do that, you stop making thyroid hormone and you decrease the blood supply. So it's less of an anesthesia risk and much better as far as how much blood flows to the thyroid for the surgeon. So that's what SSKI, and there's different forms. Lugol's is another solution, just has a little bit different concentration. There's certain contrast agents that we use for CT scans that we're used to that also have iodine. So there's other forms of it. And what is Graves' rage? I'm not sure. Right.
Is that where you don't like your doctor?
Right. It's one of two things. One, there's thyroid storm, which Dr. Adzik alluded to, which is medically, not just a little bit of hyperthyroidism, but so much that you have fever, you drop your blood pressure, and you end up very sick, like in the intensive care unit. That's thyroid storm, which would be a medical thyroid rage. Thyroid rage, as far as psychosocial, might just be that you're being, so affected as far as just how you feel and what your emotions are, that it's kind of uncontrolled kind of neurocognitive or psychosocial impact of Graves' disease. We've had some patients that actually enjoy the hyperthyroidism phase because they're so revved up. It's like, crazy coffee all the time type of stuff. And it can make people a little bit like psychosis. It can really change on how they feel and how they act, and they can almost get addicted to it, that they enjoy that feeling. But Kimberly had another.
Yeah, well, I'm a Graves patient myself, and I've been on a lot of Graves forums, and it's actually the latter. When you say Graves rage, it's kind of that, okay, something little just completely tripped me off, and I'm going ballistic, and I know it was not a big deal, but just all of a sudden I need to drop somebody, and that's rage.
Right. And some of that might be underlining and the Graves is making it worse, right? So what I usually try to tell families is we can't fix everything, but the things that we do fix we'll take credit for type of thing. So there are some baseline things. Some people have some anxiousness, right? It can be part of just the person or the family history, depressive mood, oppositional defiant behavior. There are certain things that run in families that are unrelated to the hyperthyroidism, that you throw hyperthyroidism on top of it, and it just becomes, uncontrollable and unlivable. So many things, we don't say that those are there, but we warn patients that if they don't go away, that we still need to think about, behavioral health as an option. But it really does impact how certain people feel, and it's not always related, as I said before, to the number. Different people respond to those numbers and to this disease differently. And it's hard to know exactly why that is. The other question, if you have the thyroid removed, does your autoimmune attack another organ? I think the idea of the autoimmune diseases run in families. So if you remember that kind of overlying circle diagram that I showed you, there are certain genetic factors that predispose people to autoimmune disease. So other organs can be affected, but it's not really that because of the Graves' disease, it's just an association, so it's not really a causation. So if you remove the thyroid disease, you still don't remove the genetic predisposition, and you still don't remove that there could be another trigger in the environment, another occurrence that all of a sudden you have a second autoimmune disease. So if you have one, you're at risk of others, depends which one that is, and if it's in your family, then people are at varying risk as far as which ones they're going to develop. So just removing the thyroid doesn't decrease the risk. You still have that other risk because of the underlying genetic predisposition.
And in adults, there have been reports of people post-thyroidectomy who develop years later their eye orbitopathy. I don't know if it's ever happened to your patients and kids, because I don't think we've seen it.
Who developed it?
Post-thyroidectomy eye disease later on. Because usually in kids, their eye symptoms occur very closely to the onset of their hyperthyroidism. So
Yeah.
it just brings home the point that it's an autoimmune disease to answer that question, so.
Right. And that you should never smoke, because it increases the risk later on, right?
Yeah.
Right?
And hopefully it inspires parents who do smoke to consider
Right.
cessation, stopping for their kids.
We have had patients the other way. They presented first with eye disease and very little symptoms, because
Yeah.
we've had some referrals that first, and oftentimes it's unilateral, it's not necessarily both eyes, and then the ophthalmologist, at least in our center, decides to do appropriate screening, discovers that the T3 or the TSI are elevated. All right. What should parents of dual diagnosis of 2 active autoimmune issues be concerned about, and where would you recommend we find additional resources? I guess it depends on which 2 autoimmune diseases you have. So the endocrine system certainly is a target of autoimmune disease, so diabetes and thyroid are really common associations. But it affects, as I showed you on that one slide, lots of different disorders. So going to a center that has subspecialty, multi-subspecialty availability and increased resources, I think is always easier, because communication's very easy. I mean, we call, text, email, and so you end up under a team, and occasionally we'll throw in, it might be a dermatology, or it might be an allergist, someone that's not a typical member of the Thyroid Center, but is within CHOP. So it makes it much easier, whether if you're at a children's hospital that provides, those types of resources, to not be traveling between places and receive care under one roof. It just increases communication, I think provides better care.
And I think it's true as well that we try to coordinate all the appointments on one day. We do that many times for the family's convenience.
Right.
No,
Take turns.
no,
More?
the days are all for you, buddy.
All right. So either that's, I didn't do a good job, or I raised too many questions. So if one child in the family has Graves, do other children in the family have an increased chance of developing Graves? It's interesting. If you have one, as other families here that have multiple people in families, if you have one autoimmune disease, you're at risk of other autoimmune diseases. If you have Graves, the other siblings may have nothing. They may have hypothyroidism. So it's hard to, without knowing the numbers off the top of my head, I think you are at increased risk, but it doesn't mean if you have Graves that everyone's going to have Graves, right? It can be this kind of skipping people, and it can be the opposite. It can be hypothyroidism, and it's all related to those pools of antibodies and how the immune system is reacting with the thyroid. So I think it is an increased risk, but it's more common, I think, to see mixed thyroid disorders within the family, not necessarily 3 children with Graves' disease. For a child with Graves and type 1 diabetes, what additional testing, for instance, autoimmune adrenal disease, do you perform? Any concerns for polyautoimmune syndrome or other issues later on for this population? Absolutely. The more autoimmune diseases you have within an individual person, the increase the risk. Again, diabetes is more commonly associated with hypothyroidism, with Hashimoto's thyroiditis, but there are a number of disorders, and then it depends on how you batch them, whether you call it a type 1 or a type 2 polyautoimmune syndrome. But it just comes down to screening, educating the families what the signs and symptoms are. For adrenal disease, if you have diabetes and you start requiring less insulin and you're having low blood sugars, and you have an abdominal pain, that's one of our triggers to say, oh, we should check to make sure you don't have Addison's disease, which is autoimmune adrenal disease. So it all comes down to just being aware, going to some place that sees kids that have these types of things more frequently, and then educating the family, because that's the biggest issue. We see people a couple times a year, and if the family knows what to look for, we catch things earlier. Have you seen a correlation with patients with Graves having Lyme disease? I haven't. I can't think of off the top of my head. I'd have to research that. I don't know that I've seen that. And Lyme disease in the Northeast, we're in a hotbed of Lyme disease. And Lyme disease is, as a general pediatrician, I practiced general pediatrics before endocrine for 3 years, was another one of those that I'd refer to people that were more specialized in this, because you can check antibodies, and do you have exposure, do you have active Lyme disease? It's a very complicated situation, but off the top of my head, I don't know of an association. I'll look, I just don't know.
Who asked that question? Was there a reason why someone asked the question?
Are there, with Graves after that?
Oh,
There you go. Lyme disease is common.
I mean, again, in that circle chart I showed, it could be a trigger, because you could activate the immune system fighting Lyme. Lyme is common, so it's always hard to know, is it an association, is it a causation? But it's interesting. I'll have to look and see if it's been published. Do other diseases complicate Graves' disease? Other conditions, absolutely. And other conditions, sure. I mean, if you have diabetes and Graves' disease, it's already hard enough having one of those. Having both makes it even more complicated. If you have celiac disease, which is allergy associated with allergy against wheat products, against gluten, then that certainly makes it more difficult, because then you're wondering always, are you absorbing your medicine as well if you have a autoimmune disease in your gut? And then other syndromes, Turner syndrome and Down syndrome. Graves' disease can be very difficult when you start throwing in other conditions or other diseases at the same time. It's hard enough having one. Having two sometimes definitely, but having two at times makes it more complicated. If a child has radioactive iodine, will it eventually die off, so I think with the thyroid, or when do you know if you need to have another dose of radioactive iodine? So when you give someone radioactive iodine, we start following levels every month, and what we are looking for is that the T3 and the T4 level drop. Oftentimes it's coincident with that TSH going up. So we're checking every month, and so almost everybody will have an initial drop. The question is it sustained, and you eventually reach hypothyroidism? And so you follow them until you get to that point. If all of a sudden it switches, you start them on medicine, because we see this occasionally. They develop hypothyroidism, you start them on thyroid hormone replacement, and all of a sudden they start to have signs or symptoms again, or lab findings of hyperthyroidism. You have to wonder if it's the Graves coming back, or if we're over-treating, because now we're giving somebody thyroid hormone. And the way to figure that out is to look at the T3. So we can't really give people enough T4 to make their T3 high. So if you see high T3 post-radioactive iodine, put someone on medicine, your Graves is back. And we can look at the TSI. But the TSI can take 3 years, 4 years to go away afterwards. So it can recur if we have to give a second dose if the family doesn't want surgery or is not a good surgical candidate, or you don't have a high-volume surgeon. We usually wait at least 3 to 6 months after one dose, because we don't want to give people back-to-back and not figure out if the first dose worked. So we drag our feet and see if it worked. And if we get to that point, then we have to decide what the next step is. If you have radioiodine treatment, can you then have surgery to remove it? Yes. We've had a number of patients that we attempted, they had recurrence, and then they just had it. And Dr. Adzik's happy to see them. And you don't have, it is possible, I guess, post-surgery. We haven't had any, but there are patients out there that if they don't have a complete thyroidectomy or near complete thyroidectomy, that they could have recurrence of Graves. So it is possible. But if you have radioactive iodine, you fail, you don't want to try a second dose, then it is possible to have surgical removal of your thyroid. Is remission achieved while on medication? Does remission end treatment? So if you fall into the 30%, 30 to 40% that achieve remission, and remission's defined that it wasn't there for 6 to 12 months, there's no recurrence in 6 to 12 months, then you can achieve remission. I think I was talking, I don't remember who was in the audience, someone, right, for 8 years, I think someone has a family member that's been in remission. So, if you're going to recur, it's usually in the first year, and once you start going out, then the chances of recurrence are much lower. There's, unfortunately, in life and medicine, nothing's impossible. So again, even at 8 years, you still have to be aware and think if I'm feeling funny, and I haven't had my thyroid checked, and I'm getting anxious, nervous, jittery, is it life? Is it something else? Then if it's been a while, you should check your thyroid functions. But usually when you achieve long-lasting remission, it does stay. Should you base your medical dose on blood work or symptoms? That's a good question. I think it's even more complicated in hypothyroidism patients. You have to treat to get the T3 and T4 normal, and then once that happens, that's the question that we're trying to do the study. So for people that continue to have symptoms despite normal numbers, that's like signs and symptoms of hyperthyroidism with biochemical euthyroidism is the fancy way of saying it. Your numbers are normal, but you still feel crummy, right? We don't know. But that's what we're trying to figure out the study. Is it just the normalization of thyroid functions? Is it the antibody level? Is it both? It's a great question, and I'm super interested. So whoever wrote the question, if you still have symptoms, interested to know what they are. When thyroid levels stabilize, will the hair grow back? So losing hair is not uncommon for autoimmune thyroid disease. Hypothyroidism, I think, is more common again than hyper. So we have patients that even if they have a period, a month or two of hypothyroidism, actually I just saw someone 2 weeks ago, and some people have hair twirling as kind of a habit type of thing, and they had traction alopecia. They were losing hair even though their numbers normalized after a month or two from that one spot. It'll grow back. But once you normalize numbers, the brittleness of the hair loss should improve, but it's certainly not like instantly. It's months before that happens. So again, another thing that we have to think about. And there is an autoimmune form of hair loss also, right? So if you have one, you can still have alopecia areata. You can have other reasons for that, and sometimes we then have to involve dermatology to help us manage that if they do steroid injections or some other treatment for that particular area. How does vitamin D and Graves work together? Should I increase vitamin D or decrease while living with Graves? Vitamin D is, when I was in training, 20 was the cutoff. If you're above 20, you're fine. Now it's moved up to 30. Before surgery, it's clearly important. But super vitamin D dosing is probably, there's no data to support that helps with Graves, and it is a fat-soluble vitamin, so you can end up with toxicity. So maintaining normal numbers is definitely worthwhile. Going crazy with any of these selenium, vitamin D, any of these things that have an association, but we don't know that they're causative or that they help improve or that they do anything to decrease medicine or need for definitive therapy. There's just no research that supports that. I think normalizing is good, and there's no harm to that. And last, no, there's more? All right. If you have surgery, do you no longer have Graves? Do you still take meds daily? Well, if you have surgery and the surgeon removes the thyroid, the antibody levels, so if you think about TSI as Graves, will decrease, but it takes time. So you can still have the eye disease. So we counsel patients that eye disease should not worsen with surgery, but it may not get better. And I think you said at least 6-12, if not longer.
Yeah.
So-
Definitely, in terms of any kind of surgical rehabilitation, you would want to wait years. But I think getting back to the whole concept of autoimmune, I think if you smoked, even if you had your thyroid removed, you're putting yourself at risk for having worsening eye disease. So I think you don't want to think of yourself as a person having a disease as it making you a different person. But I think in your mind, you should still think, I have this propensity to make myself sicker if I were to smoke, or if for some reason I didn't have good control of my thyroid function.
And a total thyroidectomy is not 100%. I mean, there's always going to be some cells left, and maybe that's why the TSI may not completely disappear, or at least have the risk of coming back. But there may be a little bit of thyroid tissue left that your body could respond to. But as far as the clinical condition of Graves, it goes away. And I think people feel better if they've reached a point where, they're a couple of years into therapy, we've normalized the numbers and they still feel better, they still don't feel better. We haven't had a patient come back after definitive therapy, whether it was surgery, radioactive iodine, and say, that was a terrible decision. They, in general, feel better. trying to get their numbers normalized. Hypothyroidism, again, I'm not minimizing that. There's some patients that just don't feel the same, and that is a very real group. I think it's less common, and so I still think on a whole, for patients that have reached that point of frustration, definitive therapy really does play a role, and people do feel better once they pursue that path. What's the likelihood of early puberty after the thyroid was removed or ablated? It's interesting. In Graves, you'll see increased growth. So if you look at a patient and look at their linear growth and at their bones, if we do x-rays of their bones at bone age, I don't know if your endocrinologists have done that, they increase their growth, but they don't advance their skeletal maturation, and they don't go into early puberty. In fact, they won't go into puberty normally unless you control their Graves' disease. So if they're at that fence, because the average age for girls to have their first period is 12, so the average age onset of puberty is around 10, and boys, so about 8 to 10 is when things start for girls, and boys are a little bit later. So if they're on that fence, they have hyperthyroidism, you normalize it. They may have had a delay, and then all of a sudden they start and they go a little bit faster. So if you're right on that fence, yeah, you can finally kick yourself into puberty if we normalize hyperthyroidism. If you're 4 or 5 and we treat your Graves' disease, there's no increased risk of early puberty. So it depends on when you present and what your kind of family history of normal onset for puberty for your family is. And does puberty affect Graves' disease, treatment, et cetera? How does it affect development? So controlled Graves' disease, 1, adequately controlled by the provider, and then 2, adequately controlled by a compliant patient, which are 2 challenges, should not affect growth in puberty. So if you normalize numbers, you should achieve normal growth, normal development. The boys that present before puberty and they grow a little bit taller, sometimes they end up a little bit taller. It's not a good treatment for short stature, but that is true. Just like it's not a good treatment for weight loss. Diet and exercise still are the way to go, not stopping to take your medicine. You have normal growth and development if you control your puberty. It's just during puberty, trying to convince people that they really still need to take their medicine can be the challenge. And I think there's a very high risk, like 10 to 12-year-olds, 10 to 14-year-olds, where you think, and they've had Graves' disease or they've had diabetes, they're old enough to know better, but they really aren't old enough to know better. It really does take family involvement and trying to avoid butting heads. Did you take your medicine? I didn't take it. The back and forth that we all have with our kids. All right. So what are your thoughts regarding Armour versus Synthroid, advantages and disadvantages? It was going to come up. So Armour is desiccated thyroid hormone. And there's a group of people that think synthetic versus desiccated, there's a big difference as far as the type of medicine. They're both good medicines. They're both FDA approved. So these aren't like someone's in the backwoods cooking up desiccated pig thyroid and then giving it to patients. So these are regulated medicines. But I don't think the issue is whether synthetic versus natural is the discussion, because natural is human. It's taking human thyroid, not humans taking porcine or bovine thyroid. So I think the discussion is T4 alone adequate for patients, or is combined therapy T3 and T4? And the advantage of taking thyroid hormone that's desiccated is it has some T3 in it and T4, and some patients feel better on it. The challenge is that there's different ratios, and it's set in the pill of Armour or Thyrolar. There's a bunch of them. So it's hard to adjust those compared to giving someone T4 and T3. Sometimes you can get to the same point, and you have more control by doing dual therapy. The challenge in 2014 is T4 is a once-a-day medicine. T3 is a 2 to 3 time a day medicine. There isn't a form of T3 yet that allows you to take it once and to kind of mimic what your body would have done if you had your thyroid gland. So that group of patients, like I said, I don't want to minimize people don't feel well. In training, my mentors would have said I was crazy. People don't need T3, but I believe some people feel better on it. And if you talk to people that are on it, they really do feel better on it. If you keep their numbers normal and they feel better, then you haven't done any harm. You just have to follow their numbers. But it is a more complicated approach, and I think a lot of people don't need it, but there are some that do. What's your experience and perspective on natural disease therapy meds being used successfully for patients following the STTM protocol? I don't know the STTM protocol. Stop the thyroid madness protocol. But the protocol specifically, yeah, I mean, we can talk afterwards if someone has a particular question. Oh, go
We
ahead.
actually ask patients who have dry eyes to take fish oil or flaxseed oil, which has anti-metalloproteinase activity. So that is a natural anti-inflammatory. I don't know if, have you ever seen the role of fish oil or flaxseed oil in any way for hypothyroidism, autoimmune disease?
I haven't.
So certainly for your eyes and your eye health and your skin health, 1,000 milligrams a day. It comes in a solution form. It tastes terrible. And you can get it flavored at like a Whole Foods or a Wegmans or a natural food store. And the pill is sometimes hard to swallow because it's 1,000 milligrams. So if you can find it in smaller doses, I typically send parents to Amazon because they can find combination flaxseed oil or fish oil with some other kinds of oils. And that's not a bad thing, especially if you have the dry eyes. But I don't know anything about that.
All right, a couple more, and then we'll ask, and then individual questions after if you guys have any additional ones we didn't answer. So how do you get numbers down to get ready for surgery? I think we talked a little bit about antithyroid meds, propranolol, and then we use potassium iodine to get things normal if they're not normal prior. Someone asked a question about joint pain. Joint pain, again, if you're on methimazole, you're on Tapazole, can be related. So arthralgias are not uncommon, and if you continue to take if you continue to take Tapazole, your joint pain may not go away. If you're not on Tapazole and you're having joint pain, again, it could be another autoimmune disease. So depends where you are in treatment, and if you have you can let me know afterwards, I guess, if you have a specific question. But it's like the hives type of thing. If you keep going on the medicine, you may continue to have the joint pain. In a patient with protruding eyes and no optic nerve damage, is a patient with protruding eyes and no optic nerve damage a candidate for radioactive iodine?
So the consensus is that if you have inactive disease, in other words, your eyes are protruding, but they haven't changed over a good 6 to 12 months, and your TSIs are normal, that you're in this static phase, that you won't make your disease worse by having radioactive iodine treatment. If you are in the active phase, though, we typically will treat a patient prophylactically with an oral steroid, so a few days before treatment, and then a taper afterwards, up to 3 months, actually. And that's been shown to be helpful in preventing progression of the eye symptoms.
All right, I think we're
Good.
done. Thank you. So if you have questions afterwards, are there any other questions? I guess we'll field them individually. Yep, Kimberly?
We got a question recently about the HPV vaccine and Graves' disease or autoimmunity in general, and I tried to find some info for this person, and really all I found was one big, huge study that said no connection to autoimmune diseases, but it was funded by the manufacturer.
I haven't seen anything in my reading, but I can research as well. It's been around, I think, long enough now that we're probably reaching that point where if there is something that it's going to start becoming more obvious. But I haven't seen anything either off the top of my head. Should a person with Graves' disease have a flu shot? There's absolutely no reason not to. So if you want to decrease the likelihood of getting the flu, influenza and not just the common cold, I think it's worthwhile. I don't see any problem in doing that. So the question is, if prior to starting treatment, itching or with hives? Just itching. So I think there is potentially an association with pruritus, just itchiness and Graves, and also patients. I've had 2 patients this year present with hives prior to the onset, or prior to the diagnosis of Graves, and go on methimazole, and that's a very frustrating situation because you have hives. you give a medicine that increases the risk of having hives. It usually causes it to flare. And so it can be very challenging. And at least from my experience this year, I certainly haven't won the battle of trying to keep the medicine going and controlling the hives, despite like 3 different medicines by an allergist for the hives. Regular old antihistamines, an antacid, like Zantac, and even steroids. So it can be very challenging, but the itchiness may go away if she's hyperthyroid and not having hives once you start controlling the Graves' disease. Well, one more. Can Graves' disease cause chest pain? Depends on your heart rate, right? So you can have palpitations, which is just that sensation that you feel like your heart's pounding out of your chest type of thing. So that's common, but actually pain itself, and if it persisted, didn't go away, then I would talk to cardiology just to make sure that whether it's an association or if there's something else that's going on as far as cardiac function. All right. Thank you, everybody, for joining us this morning, and we'll take questions afterwards. Thank you, Kimberly, for helping to host.